Good afternoon, folks, and welcome to today's webinar. Thanks so much for taking the time to join us. Today's webinar will be entitled Taking Charge of Your Financial Performance. We appreciate your attendance today, and then we hope to present you with an insightful look at how to address some of the common issues that are affecting HIM and revenue cycle departments all across America. Today's webinar will cover the journey that Hunt Regional Healthcare has experienced in its efforts to improve their coding accuracy and their financial performance. We'll start by reviewing the initial conditions and the challenges that Hunt was experiencing, followed by their selection and implementation of eValuator, Streamline Health's automated pre-bill coding analysis platform. We'll review the impressive results that they have been generating, and then we'll close with their future plans to continue building on their financial improvements. Before we begin, just a few housekeeping notes. All attendees in the webinar have been muted, but you can still submit questions using the questions feature in the GoToWebinar console in the margin of your screen. We'll address all questions at the end of the presentation, time permitting. Today's webinar is being recorded, and it will be posted on the website www.streamlinehealth.net after the event. Today's presenter is Jennifer Cooper, the Director of Health Information Management and Privacy Officer at Hunt Regional Healthcare in Greenville, Texas. Jennifer has a wealth of experience in HIM, which she began with her bachelor's degree in Health Information Administration from Indiana University. She followed that with her master's in Health Informatics and Information Management from the University of Tennessee. While at college, she also gained practical experience by working as a file and scanning clerk at various healthcare organizations, and she's been with Hunt Regional Healthcare since 2010. During her tenure with Hunt Regional, she supported some very important initiatives, including a master patient index cleanup, as well as the startup and the oversight of their CDI program. And with that, please welcome Jennifer Cooper.
Thank you, Dave, for the introduction. And thank you guys for attending the webinar today. If you want to go ahead and go to the next slide, please. So as Dave said, I work at Hunt Regional Healthcare in Greenville, Texas. We are a standalone independent hospital, serving acute care patients in 139 beds. We have an emergency department, and we actually also have two other freestanding emergency departments and the outer edges of our county. We have a level 3 NICU and a maternity ward. We have a cancer center, cardiac rehab. We do inpatient and outpatient procedures, just a variety of things. As you can see on the screen, we had about 7,100 annual discharges. Our patient revenue is $180 million. Our CMI right now is 1.39. That's what we're reporting. And we primarily use Meditech as our EHR. And if you want to go on to the next slide. So before we started using Streamline Health, I'll get into the background history of our coding department. About 5 years ago, we had outsourced our coding department. It was about 2014. And then we decided to bring that back in October of 2019. So working with our outsourced company, we had about 10 coders. Not all of those coders were inpatient coders. I think we had about 2 to 3 inpatient coders. Our expected productivity for those inpatient coders was 2.5 per hour or 18 per day. And then, of course, we expected their accuracy to be about 95%. They were reporting 93 to 100% of their accuracy, but that got to a point where they had stopped doing inpatient audits, and the volume of their inpatient audits wasn't as much as we would have expected to report to us. So we had some issues with our coding company, and that was one reason why we decided to bring our coding back in-house. So as of today, we have all of our coders in-house. Between April of 2019 to April of 2020, we ramped up our coding team, and we brought them all back in-house. So we really focused on bringing actual coders in, and we didn't quite have that focus on of auditing. So we had implemented actually Streamline Health eValuator prior to bringing our coders back in-house. So we did utilize eValuator while we still had our outsourced coders. And part of that was because we were questioning the accuracy that they were reporting. So we wanted something that was more aggressive and what we can find in terms of our accuracy. Go ahead and turn to the next slide. So the case coding accuracy, this was just a little demographic of that. We were getting individual coding accuracies from our coding outsourced company, but again, the volume of cases was very low. So we again questioned that. We questioned the accuracy and the financial impact that was having. And then of course we just didn't have control of the coders that we had. So it was challenging for us to really know what was going on with our accounts. So when I came across eValuator, it was more so, it just kind of came across in an email. I took a look at the information. I thought, wow, that's really impressive that they're doing, 100% of your coded data. And I was just intrigued by the idea of what it can do to impact our financial performance and increase our accuracy. So I took a look at it and got with the people from Streamline to do an analysis of what it could do for us. So when there we go. Yes, thank you, Dave. So we're really trying to find what can we do to, check our outsourced coding department to determine, what were they reporting? Was it true? Was it accurate? Was it enough? And it also enabled us to bring the coding back in-house. So when I was looking at eValuator, there was a couple of things that we were looking at. Of course, the timing and coding of analysis and optimization. So we were able to review the software tool to determine if we can do pre or post-bill coding and post-bill auditing and what that would look for us, which it can do both, which was great. We wanted something that could implement with our current workflow. And like I mentioned before, we currently use Meditech, and we do use Meditech Magic 567. We also wanted it just be easy to use and easy to implement. And we wanted to identify not just undercoding, but overcoding, because we do want to make sure that we are accurate, whether we're getting paid more or paid less. It's about the integrity of what we're coding. And we did want to also prioritize what we could review. So with Streamline, there's different ways that you can make the tool work for you as far as how to prioritize certain cases. And we also had with Streamline the ability to get some auditor support. So like I had mentioned, we really focused on building our team to code, not necessarily finding some auditors. While I do have a coding manager who can do audits, the work just became a lot. So it was nice to have the option to have auditor support with Streamline. Go ahead and move to the next slide. So the way that Streamline or eValuator works, Streamline is the company, eValuator is the tool. I always have to remind my staff that when we talk about vendors. So the way that eValuator works is it goes, your coding just does as normal, and it goes once you hit submit or however you complete your coding, it goes into the Streamline eValuator tool, where it will run all of your coded data through their rule-based engine and determine if it meets a specific threshold. So when I mean threshold, I mean, does it have a likelihood of change? Do we want it to review 100% of the accounts that go through, 60%, 50%, 40%, so on and so forth? We chose, just an example, 50% of likelihood of change is what we want to go through the engine. So if it meets that threshold, it will go to the eValuator tool for review. And by threshold, like I said, the likelihood of change, but it also depends on the rules that it hits. So I believe there are over 1,500, 1,600 different rules that it can trigger for review. Rules could be the length of stay is greater than the geometric length of stay. The reimbursement is less than the charges. It could be based on principal diagnosis or procedures, just different coding guidelines, coding clinics, etc. So once it hits that rule, and it meets that threshold of change, that's when it goes into that queue to be reviewed. And it's routed to the workflow to be reviewed. It can be reviewed by internal auditors. So if you have auditors on staff that want to review that, that's what they would do. Or you can utilize Streamline Health auditors to do the reviews for you. So they go to that resource, it gets reviewed, and then they have the option to say, oh, no, this is actually okay, go ahead and send it through. If it gets sent through past the auditor, it just basically goes back to billing. If they say, nope, this one needs to be reviewed or this one needs a query, they add their notes and their narrative as to why. There's very easy icons to follow that describe what the change was per the auditor. And then at that point, it goes to the coder for their review. The coder can then review it, say, yes, I agree, make their notes in eValuator, and then they do their coding per usual in the coding system. They submit and it goes back through. So there's that route. So if it doesn't meet the threshold, it just goes from coding directly to eValuator. Nope, it doesn't hit any thresholds, and it goes back onto the billing side, and then that review is complete. You move on to the next slide. So after implementation, we found, just looking at our round of analysis, that there's definitely some room for improvement. We've had, a few that were overcoded, but several that were undercoded that would make a financial impact. So we needed to decide how to create that workflow for us. And I was actually really impressed with the rules that we're hitting and the reviews that were being done, and just the ease of use of the product. Next slide, please. So I kind of already spoke about this, but this is an automated analysis of your coding prior to billing. And again, it can be pre or post bill. When I say pre-bill, it's going to stop the account before it gets into coding. So there should be a rule or a script rule written to go ahead and do that. And then once the review is complete, once you submit it, that's when it goes to billing. Post bill could be, you just don't have that script change where it says, nope, I don't want it to go to billing until it's been reviewed. And again, the priority of case prioritization by the likelihood of change, and you can see, I'm so sorry, the automated analysis of inpatient coding. I want to speak to that one more real quick. So what I like about this is that it's sending every single account that you code through the eValuator tool for analysis, as opposed to us picking just 10 accounts per week per coder. If I only have 2 inpatient coders, that's only 20 accounts per week that are actually being reviewed. Where you can see in our first month, we had 250 accounts actually go through eValuator for review. And that was pretty impressive to me. Now, not all of those had a change necessarily, or not all of those will have a change, but just the volume that's actually being reviewed is more comforting to me than just a select 5 a week. And that's what really impressed me about this. And then initially, we wanted to do the audits ourselves, but we didn't have that manpower to do that. So we took on eValuator's auditors to do that for us, and they addressed all of the backlog of cases that we had. So we actually started this in 2019. I believe it was February 2019. We thought, oh, sure, we can audit these. It should only be so many per day. But auditing takes time, and we also have other functions to complete. So we decided, let's go ahead and get eValuator to get in and do our reviews for us. And they were able to do that and get those cases reviewed quickly and timely. And one thing I also want to talk about was just how I selected the thresholds. We actually started, I think, a little bit higher, and we decided, that just depending on the volume, we just decided to go down to 50 to see how much we can get. And we're averaging about that 250 a month or so at 50%. So we didn't want to go if it was a 60% chance of likelihood of change, that would mean fewer. If it was 70% likelihood of change, that would be even fewer. But if we had 40%, that would be even more. 30% would be even more. So we had to find a balance, and 50% just seemed to work out for us, and that's why we chose 50%. And I think that's done for that slide. You can go ahead and move on to the next one, please. So as of December, this is a snapshot of what we saw for our review in December. We had 256 cases that were audited. 32 of those required a change. They were either an overpayment or an underpayment. We had 3 overpayments and 29 underpayments. That turned into a $119,000 impact for those cases. And I use this just to determine, okay, where are we? So we had 256 cases audited. So where were only 32 of those required a change? So I think that was like a 90% accuracy rate. And if you look at the overall picture, when you're, let me minimize this real quick. With the actual total volume of patient discharges you have, so I'm going to just tell a bigger picture. If every single one of your accounts are going through the eValuator tool and only 32 of those actually had a change, that's actually a pretty good accuracy rate. So I'm going to read off our numbers for actually November. So we had 693 inpatient discharges. 65% of those were going without change. So that really equated to a 95% accuracy. So we had 241 of those 693 audits hit the 50% threshold, but only 34 of those required a change. So that was about a 90% accuracy rate. But when you look at the overall picture of all of the accounts that were actually going through the eValuator tool, we ended up at 95%. And of course, 95% is our required accuracy rate. So I try not to discourage my coders saying, oh, we only had 80% accuracy this month, because that was just based on what was going through, that was based on what was actually reviewed from that 50% threshold. I'm going to do some quick math real quick. Which I'm not very good at. Anyway, I'm sorry about that. But anyway, I wanted to show that overall picture. You've got to look at your total inpatient discharges and realize that every single one of those are going through the tool, whether they're actually hitting the threshold or not. If they're not hitting the threshold, then it should be fairly good. If it's a 20% likelihood of change, that's more than likely you're not going to have anything significant to change for those accuracy, for those cases. Next slide, please. And this is just a summary of audit services, trends by DRG. So there's a lot of different reports within eValuator that you can review. This is just one of the many. So you can kind of see what the trend is. We had quite a few of 807 DRGs that were the original, a lot of 194s that were the original DRG. But once Streamline auditors reviewed them, they were able to change those to, or recommend changes rather, to those DRGs. And you can see kind of what the summary is of, the revised DRG and what could have been. So it's nice to look at this because I know specifically who my OB coder is and determine, okay, what assistance do they need, what problems are they having, what education do they need, and I can provide that feedback to the auditor or to the coder saying, hey, this is what's going on. Why don't we do some education, focused education on this particular subject. And then with those 194s, that's a target for CDI to review. So it's not just a tool for coding, but it can also be for CDI saying, hey, Streamline auditors recommended a query for this 194 DRG to move it into an 871 DRG. Do you agree with that query? Did you review it? Was it just a missed query? So you can use those reports not just for coding, but for CDI as well, and just kind of make it a working relationship, especially if there are missed query opportunities when CDI is actually reviewing those cases. It's an opportunity for their education as well to determine, okay, I've missed this. This is why I missed it, or hey, we didn't even review that chart. But how do we? Yeah, we agree with that query. So it's an opportunity to really strengthen that relationship between CDI and coding, and even strengthen your CDI program. Next slide. So this is another report. It's DRG accuracy by coder, and it breaks it down obviously by coder. We don't have their names listed obviously, and that's quite a bit of coders that I don't have anymore. So some of these were our contract coders that we previously had, but some of these that are, got the higher volumes, you can see the number of accounts that were audited, the accounts with changes, their change rate, if their DRGs were increases or decreases, their overall accuracy rate, and then of course the financial information that goes with that. So again, this just kind of points out, whoa, we've got some, like this one down here. Well, they got a 50% accuracy rate, but you can see why they only had 6 accounts audited. Or, hey, these guys are performing at 100%, but again, that accounts audited is low. So to me, that means that I know that these coders are no longer here. But that was kind of my issue with our contract coding, is they were saying, oh, you guys are, this coder's at 100%. Well, they only reviewed 3 accounts during that time frame. So of course their accuracy is probably going to be better with, the fewer accounts that you audit. So again, that's the beauty of having this pre-bill, reviewing every single account and making sure it meets that threshold. But again, this kind of just shows me, for me, what their individual accuracy rate is and, what issues they might be having. It's not as detailed as the DRG trending one was, but this still gives me a good snapshot. And it's nice to see the number of cases audited and things of that nature with this one. Next slide, please. So this is a summary of our impact for the whole calendar year last year. We had 2,574 cases reviewed. 396 of those had recommended DRG changes. So 118 of those were overpayments, 278 were underpayments. So the total impact was 1.4 million. Of those so that the actual revenue impact, between those two was $583,000, almost $584,000. And then we still have quite a bit of backlog of physician queries. So what I mean that we have auditors that are suggesting queries. We have quite a few out there, as you can see, 262. They are recommending queries, and it's up to my team to determine, yes, that query was necessary, or no, it wasn't. And depending on the response to those queries, that could also impact our revenue positively or negatively. So that bottom number, revenue impact from physician queries, that's potential. So that's potential money sitting out there that could be due us if we get these queries out to the doctors, are able to rebill, so on and so forth. So actually the total impact on revenue integrity was 1.4, but that net value is just over $1 million if you take out the overpayments and correct it. So there's a lot of room for improvement. There's a lot of room for education, and there's just a lot of room for some revenue that we could be gaining. Should we review these queries and agree with them, or should we just continue to focus on our underpayments and overpayments and see what education our coders need to have? Next slide, please. And again, this is also a snapshot of 2020 calendar year. This is just the monthly and cumulative financial impact report. As you can see, the monthly impact is down there in blue, and then our cumulative impact from month to month is in purple, and you can just see a steady increase in that financial impact that's positive. And this slide is just a summary of kind of our progress. We started with using eValuator when we had our contract company, and just kind of, like I said, questioning what their accuracy was and hoping that this tool would shed some light. We did see quite a bit of, over and underpayments in that initial analysis, and now we're really moving towards that trend of fine-tuning our accuracy. We're still having improvement in our financial impact, and just working through processes, but even with CDI and coding to determine what our queries, how to work our queries and how to work together to re-review those that we may have missed. So it provides a lot of education. There's also a function within eValuator to review outpatients. So primarily I spoke to inpatients. Obviously DRGs are where you get to see some big financial gains depending on which way you go. So for outpatient, there is a similar work where it goes through eValuator just like an inpatient, depending on what the threshold is. It can be reviewed or not reviewed. A lot of the rules are, it could be a charge-related rule. It could be, a edit-related rule. So those are things that we're looking into to implement as well for our outpatient coding, so that we can also review our outpatient coding accuracy and get other departments involved for charge capture if it happens to be a charge capture issue. So there are more ways you can use eValuator.
As I was saying, I was thanking Jennifer so much for all the insights that she was sharing here regarding the strides they're making towards improving their coding accuracy and their overall financial performance that results from it. At this point, we are done with the prepared moments, and we would very much like any questions that you have. And hold on, I think I see one here. And this question says, does this product work with other Meditech applications besides Magic, such as Meditech Expanse? The answer for that is yes, it does. As Jennifer mentioned, she does use Meditech Magic. I think she said 567, but it does work with Meditech other Meditech applications. I apologize, I can't say off the top of my head which one we have in place, but we are. As a matter of fact, Meditech was the very first EHR that we began work with. All right. And then I have another question here. Hopefully Jennifer's back. Jennifer, is your audio working again?
Can you hear me?
I can. Excellent. Okay.
Okay, good.
I just fielded one question regarding the functionality with the other Meditech versions.
Yeah.
Here's one I think you can answer. This says, how did you get executive approval for a new project? And then also, how about IT, I guess IT department approval?
Yeah. So after Streamline did a analysis for us to just kind of determine what the return on investment might be. So after looking at it, I took it over to my CFO, and because it wasn't a budgeted item at the time, and he took a look at it and he goes, oh, that's really interesting. I think we should do this. And then he actually had spoken with some other executives outside of our facility that had previously worked for Streamline as well. And they agreed that it was a good return on investment. And that's really how I got the buy-in from my administrator. He says, as long as it's paying for itself, let's go ahead and do it. And I feel like it has for us. And then from an IT perspective, we do have a pretty intense approval process for IT. And basically, we just want to make sure our PHI is protected and whatnot. So it went through their various stages of review, and as long as it passed their security and really tests, they said, yep, we can go ahead and do it and move forward. I had a designated IT person work with me on this project. Basically what we needed were some files from Meditech to push over to Streamline to receive our data. And then it's actually only, it's not bi-directional, it's one direction. So it goes from Meditech to, at least the way we have it functioning right now, it goes from Meditech to Streamline. So it was really just, like I said, a couple different files and formats that IT had to work through. And then, of course, the build through eValuator that made that work. So as long as I had the CFO's approval, I would be able to get, the IT approval as long as it checked their security and security measures and whatnot. So we were able to get that approved actually pretty quickly. And the implementation was actually very smooth and easy to work with. We had at the time been working on implementing Dolby Fusion CAC and moving towards that. So a lot of what we needed for both projects worked really together, actually.
Excellent. And I might augment that answer by pointing out that as a cloud-based solution, eValuator actually is a fairly easy lift from an implementation perspective, and it certainly can reduce some of the barriers to entry for some of the folks who are wondering, oh my gosh, if I go to IT and say I want to install a hosted solution, I am not going to get the answer I want. But fortunately, as a cloud-based solution, eValuator helps you bypass a lot of that and makes it a lot easier to not only, as you mentioned, get it up and running, but per your CFO's question, it does offer a very strong return on investment. And as you mentioned, if it's something that's going to pay for itself, that's certainly going to help win over some of the approvers in your executive cycle there. We have another
Yeah.
question here, and it says, can it be used with CDI real time prior to discharge? And I can speak to that. Yes, it can. As a matter of fact, in addition to working with our own existing CDI, we're also working with some third parties. But basically, the way eValuator works with your CDI process is it would provide certain alerts that would actually pop up during the CDI process, patient safety alerts and some other things that could be helpful, and the rules would fire directly prior to the actual going into the coding process. So yes, it can help you with that. Let me take a look and see if there's any other questions here. Let me see here. Okay.
Let me speak one more thing too. Is it okay, Dave, if I speak one more thing to the implementation?
Oh, certainly.
So because, and like you said, it is cloud-based, and because it's cloud-based and it's hosted, really eValuator is doing all the support and work on it. So if they're doing all the updates, making any changes that need to be changed internally, and IT is pretty much hands off at this point. I utilized them to, get the files over to them that I needed, and from there, I haven't had to reach out to my IT support for anything eValuator related. I would go strictly to Streamline to make any changes or make it function better or differently for us. So that's kind of the benefit of having it to be cloud-based.
Most definitely. That sounds great. Thank you. I have another question here, which I think you can answer. It says, thank you for the presentation. With your process, what was the impact to your DNFB days?
So that was why we decided to not exactly do it pre-bill. So really what our process is that we go and code it. As it's been coded, it's submitted to billing. So it's not impacting our DNFB. And part of the reason why we did that is because we have a higher bill hold days than what we want. And at the time we implemented it, we weren't caught up to that bill hold day. So we were afraid that if we were to make any changes, it would, continue to increase our DNFB. So we decided to just code it, submit it. If it's reviewed by Streamline and sent back to us, we would review it and then just have it rebuild, because if it's rebuild within, a certain amount of days, it should be fine. And we haven't had any red flags from an audit perspective, but we did not decide to hold the account prior to it being reviewed because we did not want our DNFB to increase, because we had already had our own challenges in that area. We're getting to a point though where our discharge not final coded days is, within that bill hold. So if we decide to really move to that pre-bill and have that stop before it goes to really Meditech for final billing, final coding and final billing, that we have some wiggle room to do that where it won't impact our DNFB.
Excellent.
I hope that answers your question.
No, I think that's great. And to your point, you're absolutely right. One of the, I think, benefits of eValuator is that you do have the flexibility to adjust how many actual cases are meeting your threshold. So as you referenced, if you have fewer resources, you may want to actually adjust your threshold a little bit higher. So only the higher impact cases, aka the cases with the greater potential undercoding or overcoding, come through and are actually presented to your reviewer's work pool. One other thing I'll point out is that in addition to the likelihood of change threshold, which is really helpful in assessing the actual impact, or excuse me, the severity of the potential issues being flagged, it also offers a financial impact rating. And basically what that is it gauges the potential changes that it's flagged, and it basically estimates how much potential financial impact it will have to the final coded amount should the recommended changes be acted on. So in addition to, for instance, you said your 50% threshold, which means that any cases that came through of all the ones that went through eValuator and were identified with errors that could potentially have a greater than 50% chance of changing, you could also say, and I also want to take a look at all cases that were identified with a potential financial impact of $1,000 or $5,000 or what have you. By using these flexible thresholds, you can adjust the throughput based on your own resources. And to your point, you adjusted it downward a little bit to sort of catch more, if you will. Whereas were your resources more limited, you could actually adjust the thresholds upward a little bit, and then therefore have fewer cases to look at, but still know you're hitting the highest impact ones. We have one more question here. It says, does the facility get to choose what rules and eValuator they want to put in place, or do they have to use all the rules within the system?
Actually,
go ahead.
Oh, so I can answer part of that. We were able to choose a couple. We were able to choose some. If we were seeing a lot of a specific rule that we didn't want to have reviewed, we decided, hey, can we eliminate that rule? So one of them was that the total charges was more than the estimated reimbursement. Well, for us, we knew that that was a potential to happen, so we decided we don't want to see that rule, and we requested that that one be turned off. I think the same thing for the actual length of stay was greater than the GLOS, and we decided to have that one turned off. But Dave, if you want to speak to any more, then please do.
No, that was great. The one thing I was going to point out was that for eValuator accounts, we have our continuing success program, and this is a team of dedicated resources who, in addition to helping your team learn how to use the eValuator system and run the cases through as efficiently and effectively as possible, they also review all of the rules that are firing and all of the cases that are being presented for review. And using their experience, they can also help identify potential situations where additional rules or certain rules are firing prematurely or in a way that isn't as effective or aren't applicable to your unique circumstances. So to your point, they could very easily turn those rules off. Another benefit of the continuing success program is that in addition to reviewing your cases that are being flagged, they also review all of the cases coming through, and they look for trends within your existing coding data to see if there are potential rules that would benefit you. So for instance, there may be trends in your coding data where it says, you know what, we aren't seeing, none of these are flagging rules, but we also know that these cases still were not coded accurately. And so using that insight, they work directly with your team to help develop those custom rules to say, you know what, we didn't have a rule for this specifically, but in reviewing your data, we see that not only is this rule needed, it would also help your success rate in terms of catching the potential issues and presenting them for you review and correction. So whether or not the rules are firing isn't the only question. It's whether or not we can also find additional rules to help you. And that's part of the eValuator programs. We have a dedicated continuing success program. Excellent. Let me take a look. And I don't see any additional questions here. So well, with that, I think that should wrap up today's webinar. But again, thank you so very much, Jennifer. It's been most enlightening to hear you and Hunt Regional's experience with the system. I think that using eValuator to address your coding accuracy and your financial performance is indeed has been a positive experience. And I hope that the HIM and the revenue cycle members of today's audience have gotten some insights and are more informed on what they can do to improve their financial performance. For anyone in the audience who is interested in learning more about this, please feel free to go to our website. You can go to www.streamlinehealth.net, and you would be looking for eValuator Or you can also look at our audit services program. As Jennifer mentioned, we have a wide array of them for both inpatient, outpatient, and pro fee. And we pride ourselves on being a comprehensive partner for revenue integrity. And one last final note here. Once again, would like to thank Jennifer so much for her help and all of her insight in preparing this. And lastly, I'd like to thank those same provider-based audience members for all you're doing to support us during this ongoing pandemic. It's certainly challenged our healthcare system in so many unprecedented ways, and we just really appreciate the entire healthcare community, both the clinicians and the administrators, for all you're doing to rise to this challenge so admirably. This concludes today's webinar. Thanks again, Jennifer, and thanks to each of you for all of your time. Have a great day and stay safe.
Thank you.
Thank you.